Hello everybody, welcome back to the ERMP and Beyond YouTube channel. Today we will see case number 10 from the ERMP 2021 previous recall questions. A 45-year-old female with dysphagia presented to radiology department for a barium swallow. The study revealed distal esophageal short segment stricture with central ulcer, which doesn't project beyond the wall of the esophagus. What is the most likely diagnosis? A. Esophageal cancer, B. Achalasia, C. Crohn's esophagitis, D. Leiomyoma. The most likely diagnosis for this patient is Crohn's esophagitis. Crohn disease is a chronic transmural inflammatory bowel disease that usually affects the distal ileum and colon, but may occur in any part of the gastrointestinal tract. Approximately 80% of patients have small bowel involvement, usually in the distal ileum, with 1/3 of patients having ileitis exclusively. Approximately 50% of patients have ileocolitis, which refers to involvement of both the ileum and colon. Approximately 20% have disease limited to the colon. In contrast to rectal involvement in patients with ulcerative colitis, 1/2 of Crohn disease patients with colitis have sparing of the rectum. Approximately 1/3 of patients have perianal disease. Approximately 5 to 15% have predominant involvement of the mouth or gastroduodenal area, while fewer patients have involvement of the esophagus and proximal small bowel. About 88% of patients with esophageal Crohn's disease also have Crohn's disease affecting other parts of the body. Approximately 33% of patients with esophageal Crohn's disease have oral ulcers at the time of symptom onset. The mid or distal esophagus is commonly affected. In general, involvement of the upper gastrointestinal tract in Crohn's disease occurs concomitantly with involvement of the lower gastrointestinal tract. The pathology of Crohn's disease is characterized by some essential features such as segmental inflammation, meaning it affects specific portions of the GI tract rather than continuous involvement. Transmural inflammation that extends through all layers of the GIT wall, from mucosa to serosa, leads to segmental fibrosis and stenosis of the alimentary canal upon healing. Ulcers can also occur due to the inflammatory process. Crohn disease begins with crypt inflammation and abscesses, which progress to tiny focal aphthoid ulcers. These mucosal lesions may develop into deep longitudinal and transverse ulcers with intervening mucosal edema, creating a characteristic cobblestoned appearance to the bowel. Finally, the hallmark of Crohn's disease histologic feature is non-caseating granulomas. Most clinical manifestations of esophageal involvement are asymptomatic or mild, with non-specific upper GI symptoms, similar to gastroesophageal reflux disease. However, symptoms such as dysphagia, odynophagia, retrosternal pain, or severe heartburn may also occur. The diagnosis depends on clinical, endoscopic, histological, and radiological evaluation. The presence of aphthoid ulcers, longitudinal ulcers, bamboo joint-like appearance, stenoses, and fistulas are endoscopic findings suggestive of the disease, and it is important to exclude the presence of Helicobacter pylori infection. On barium swallow, Crohn's disease of the esophagus appears as multiple contrast-filled outpouchings parallel to the long axis of the esophagus. Treatment is with 5-amino-salicylic acid, corticosteroids, immunomodulators, anticytokines, antibiotics, and often surgery. Early-stage esophageal cancer tends to be asymptomatic. When the lumen of the esophagus becomes progressively constricted, dysphagia commonly occurs. The patient first has difficulty swallowing solid food, then semi-solid food, and finally liquids and saliva. Because the lack of a serosal layer on the esophagus allows the smooth muscle to dilate easily, dysphagia usually presents late in the natural history of the disease. As a result, The dysphagia becomes severe enough for the patient to seek medical advice only when more than 60% of the esophageal circumference is infiltrated with cancer. Consequently, the disease is usually advanced if symptoms herald its presence. Tracheoesophageal fistula may be present in some patients on their first visit to the hospital, and more than 40% will have evidence of distant metastases. With tumours of the cardia, anorexia and weight loss usually precede the onset of dysphagia. The physical signs of esophageal tumours are those associated with the presence of distant metastases. On a barium swallow, an irregular narrowing of the esophagus is often seen. This narrowing may have a characteristic shouldering appearance. Before the narrowed segment, there may be dilatation of the esophagus due to the tumour obstructing the normal flow of contrast material. This results in a hold-up appearance on the barium swallow study. When these two findings are observed, further evaluation with endoscopy and biopsy to confirm the diagnosis is necessary. Achalasia is a neurogenic esophageal motility disorder characterized by impaired esophageal peristalsis and a lack of lower esophageal sphincter relaxation during swallowing. Achalasia is thought to be caused by a loss of ganglion cells in the myenteric plexus of the esophagus, resulting in denervation of esophageal muscle. This impaired relaxation of the lower esophageal sphincter, leading to food stasis. As a result, it can lead to esophageal dilation rather than strictures due to impaired peristalsis. Symptoms are slowly progressive dysphagia, usually to both liquids and solids, and regurgitation of undigested food. Evaluation typically includes manometry, barium swallow, and endoscopy. On a barium swallow, achalasia typically presents with a dilated esophagus, rather than stricture, that tapers abruptly at the level of the lower esophageal sphincter. This appearance is often referred to as the bird's beak sign. The esophagus appears dilated due to impaired peristalsis and failure of the lower esophageal sphincter to relax. Tram-track appearance refers to a central longitudinal lucency bounded by barium on both sides, creating a tram-track-like appearance. Treatment options of acalsia include dilation, botulinum toxin injection, and surgical myotomy. Esophageal leiomyomas are the most common benign esophageal smooth muscle tumors. The symptoms depend on the tumor size. Small tumors are usually asymptomatic. Large tumors may cause dysphagia, regurgitation, esophageal obstruction, chest pain, cough, or bleeding, which is rare. They may cause localized strictures but are less likely to present with ulcers. Esophageal leiomyoma appears as a discrete ovoid mass, rather than strictures or ulcers, that is well outlined by barium. In contrast to acute angle with the shouldering effect seen in esophageal cancer, its borders of an esophageal leiomyoma form slightly obtuse angles with the esophageal wall on barium swallow. Thanks for watching. Like and subscribe for more similar discussions.